The following podcast is part of a certified educational activity titled Democratizing the CAR-T Experience, the Principles and Practice of Outpatient Cellular Therapy. Access the entire activity and complete the post-test at peerview.com/HKJ860. Downloadable slides and practice aids are also available.
Welcome to this symposium, Democratizing the CAR-T Experience, with a focus on outpatient cell therapy in the era of expanding access. Okay, so when you look at this slide, it's a busy slide and it tells us there are so many approved products as of today and that the list is clearly growing. Not only are the products increasing, we also find that the diseases for which we have cell therapy options available are also increasing, and that is really, really good. Our projection is that this trend will continue, and we'll figure out ways to expand access to those who already have an existing indication, and for new indications to come down the line. So who are these patients that we often see that are referred for CAR-T? We'll just talk a little bit about the general patients that we tend to see in referral. Take the 60-year-old Joe, the electrician, high-grade large B-cell lymphoma, relapse after eight months after receiving R-CHOP chemotherapy, high LDH, and referred for liso-cel. Of course, that same patient will be totally eligible for axi-cel too. Then the 28-year-old dancer who had Ph-negative ELL, who did not respond significantly to two cycles of hyper-CVAD, will be a reasonable referral for CAR-T therapy. And so is a 70-year-old multiple myeloma woman who had received 4 lines of therapy, pretty much all the classes of approved agents, and in our 4th line had progressive disease. That would be a reasonable referral for cilta-cel. So our goal for today is to improve your understanding of the evidence that supports the use of CAR-T in general, augment your knowledge of patient outcomes and practical aspects with successful outpatient program, equip you with the skills that are needed to build and manage an outpatient therapy program, and provide some guidance on strategies such as telemedicine, wearable devices, optimal patient selection, and some of the tools that are essential to run a successful outpatient therapy. So my part of the symposium is to review some of the practice-changing evidence that we now have, and what is new, or what is a summary of the things that are out there for CAR-T. The one that I find most exciting, or one of the most exciting, is that we do have overall survival for cell therapy, which to me is a great deliverable for the field in general, that these treatments can actually extend life. This was ZUMA-7, 350 patients, half to axi-cel, half to standard of care, which is chemo followed by autologous transplant. Those who did not respond on the standard of care and were able to get CAR-T in the 3rd line setting, despite that crossover, it still showed an overall survival benefit, which is really good for the field. Next, I want to talk about Transform, which is liso-cel, similarly designed study where half are randomized to liso-cel and half to the standard of care, which again consisted of chemotherapy followed by autologous stem cell transplant. This study was positive in every measured outcome of interest: event-free survival, or complete response rates, progression-free survival. They were all in favor of liso-cel, and this again outlines why we want to give patients who have this relapsed disease, want to treat them as early as possible with CAR-T therapy if they meet the indications. All right, so those are clinical trials. How about in the real world? In other words, they may look good on the clinical trial. How about in the real world? There are several real world studies at least in large B-cell lymphoma, that show pretty much the same thing that we observed in the clinical trial, which is a testament to how well the patients were selected. Even though they were highly selected for clinical trial, they must have kind of mirrored real life to some extent, because what the real life data did was just to validate what we know in the clinic, what we found in the clinical trial. So this is a sample of 323 patients that received liso-cel. A lot of them were older, and more than half would not have met the strict inclusion-exclusion criteria for the liso-cel trial. And what did we see? Pretty much very, very high response rates. Median duration of response not reached. And the EFS and the preliminary OS data looks pretty good. How about in terms of safety? So this is a select. Of course, we can't talk about every publication, but this is select for a focus on the safety. What do we see? Cytokine release syndrome still happens very frequently. However, most are in the grade 1/2 category. And even neurological events still happen, but most are still in the early grade category. And what we also see by this is that even though in the clinical trial there are specific protocols for management, it seems that even in the real world setting, we are not seeing rates that are higher. If anything, we are probably seeing rates that are even lower, suggesting that as a field, the physicians are getting more comfortable managing these diseases and the toxicities, and that the setups that exist apparently are able to expand as the numbers are growing without the compromise of safety. So this is also a summary in ALL with tisa-cel, showing really more longer-term data where there were no new signals of toxicity, and the event-free survival, the median OS was not yet reached, showing that the efficacy was really pretty preserved in that population of ALL patients. All right, switching gears to multiple myeloma, I want to talk briefly about the CARTITUDE-4. Some of the earlier CARTITUDE trials have already been presented multiple times, but this is interesting, looking at how well CARTITUDE works in the earlier lines of therapy. So these are not patients who had 1 to 3 lines of therapy. Some were randomized to cilta-cel and the other to standard of care. And as you can see in this study, 208 cilta-cel, 211 standard of care, that it seems that the PFS was not reached in the cilta-cel arm, whereas it was 11.8 months in the standard of care arm. And of course, they used bridging therapy to hold the disease during the manufacturing process. But this underscores the fact that not only are earlier treatments with cell therapy beneficial in large cell lymphoma, we are actually seeing a signal that they may also be beneficial even in a different disease like multiple myeloma. So, how about ide-cel? We also find the same pattern that using patients who had only 2 to 4 lines of therapy, it just showed that the ide-cel also appeared to be more beneficial in terms of progression-free survival in the patient. So the hope is that as the access to these treatments are expanding, that we will also be able to preserve the safety pattern that we see. Because multiple myeloma approvals came a little bit later, the real-world data is still maturing, but we are also hoping that the real-world data will also support what we see in the clinical trials. So what do we see that is going to happen in the future? Of course, we cannot discuss every possible trial out there because, since CAR-Ts have been found efficacious and relatively safe, there is a myriad of new products out there. So there are a few that I selected just to let you know that it is not a static field, it's a dynamic field where things are growing very, very rapidly. So we have docaptogene autoleucel, which is BCMA targeting. Why are they doing this? We know that about a month wait for manufacture seems to be a long time, And patients often progress during that interval or get sick of something else and never get the CAR. So there's always a push to shorten that time as much as is possible. So Docaptargin or cilta-cel is a BCMA targeting CAR that is made faster using the T-Charge method. And so is Rapcaptargin or cilta-cel targeting CD19 in a similar fashion. And we all heard that the FDA has approved a manufacturing process change that will shorten the manufacturing time of axi-cel from 16 to 14 days or maybe even earlier. And yes, those few days are quite important when you are trying to get the effective treatment to the patient that needs it most. The last study I would mention is the fast production dual targeting BCMA19. So antigen escape is a standard method that helps to facilitate relapse or progression after patients have received CAR. And this is a method to try and mitigate that by targeting two rather than one receptor. And we know that early on in the ontogenesis of B-cell, CD19 may be expressed, but not longer in the mature plasma cell, although some do. So by targeting BCMA and CD19, we hope that this product will be able to prevent the antigen loss that we often see in patients who have relapse or refractory disease. So these are just a few. There are so many other clinical trials, agents being investigated in this field. So I would like to move at this time to invite Dr. Veronica Bakanova to talk about latest outpatient outcomes in cell therapy. Thank you very much.
Thank you for inviting me and for the opportunity to discuss this very interesting and exciting topic as we are really expanding on experience using CAR-T in outpatient setting. So everyone in the audience is by now familiar with this timeline of a CAR-T journey patients go through. It starts with the apheresis, CAR-T cell manufacturing, and waiting for the product to be delivered, lymphodepleting chemotherapy using fludarabine Cytoxan or bendamustine, which is typically done outpatient, followed by the CAR-T cell infusion and then monitoring, intensive monitoring for the adverse side effects. And the patient have to stay in the vicinity for 30 days. The pivotal studies have included inpatient monitoring due to many unknowns, including the time to adverse events, particularly cytokine release syndrome and in effector cell-associated neurotoxicity. But the models to deliver CAR-T cell therapy has been evolving, and there's increasing experience and a question whether it's feasible to administer CAR-T cell therapy in an ambulatory setting and monitor patients and really avoid or delay the inpatient stay. So what can go wrong? Well, what we are really worried about is alarming and severe complications of CRS and ICANS, which can become life-threatening and particularly result in a multi-organ compromise, cardiac, pulmonary, liver, kidney injury, and then also the incidence or, I think, unrecognized complication of the HLH macrophage activation syndrome manifestations. So early recognition and early treatment and intervention is necessary to prevent these high-grade complications and are really needed for optimal outcomes. But there are other potential complications: infections, neutropenic fevers, tumor lysis syndrome. And so can we manage all these outpatient? The time to CRS and ICANS is one of the variables which is important to be aware of when we select patients and products for outpatient therapy. And this is variable by the CAR-T products. The good news is that the new onset of CRS and ICANS is exceedingly rare after day 14. It just doesn't happen after day 14. We've looked at over 300 patients treated with the tisa-cel and axi-cel and a U.S. consortium, and you see here that all the events start in a week 1 or 2, and they vary by the product. These are the median number of days to CRS and ICANS by various products from the pivotal studies, and the real-world experience pretty much mirrored these numbers. As you see, it's quite variable, and for some products, such as axi-cel or ida-cel, it's a very early onset of CRS. But ICANS is typically delayed, and for some products, such as liso-cel or cilta-cel, it's not occurring until second week after infusion. Ideally, we would like to prevent this, but we are not there. The prevention strategies have not been widely implemented, and the reason is they are either not effective, such as tocilizumab prophylaxis, which hasn't been really effective, and in fact there were increased rates of ICANS in this study. But some, such as steroid prophylaxis in an axi-cel treatment, as was tested in a cohort C of ZUMA-1, had some promising results. The most data is now, or promising data are coming from use of anakinra prophylaxis. And on the last year, ASH, the itacitinib results were presented, where the patients received this JAK inhibitor from day -6 through day 26 and had low levels of ICANS and no grade 4 ICANS. At the University of Minnesota, we recently presented our results using intrathecal dexamethasone injected on venous -1+6 plus statin orally, and this resulted in relatively low rates of ICANS and very few high-grade ICANS. So in addition to the product, the patient selection is important to really implement a safe journey. The many studies listed on the bottom of the slide have analyzed the risk factors for high-grade ICANS, and uniformly, the most critical prognostic factor is disease burden. But there are others, such as inflammatory markers, and these reflect the inflammation and also the risk for the endothelial injury, which is the major pathophysiology mechanism for the ICANS and HLH. So high LDH, elevated ferritin, elevated CRP at the time of the CAR-T infusion are all increase the risk for the toxicity. The history of seizure is also important, and notably, the CNS lymphoma is really not a risk factor for neurotoxicity. So these are relevant for the patient selection and also helpful to develop the monitoring frequency on ambulatory setting. So the feasibility of outpatient infusion came from the UPenn. The team there infused tisa-cel in 78 patients with lymphoma and has shown that they have demonstrated that, in fact, 2/3 of the patients were managed outpatient and only 1/3 was admitted. Importantly to note that most of these patients received bendamustine as lymphodepleting chemotherapy, and the length of stay for those who were admitted was only 5 days. And they showed that indeed there were no high-grade toxicities, and the response rates and survival was similar to that reported in a clinical trial. We have validated this data in a U.S. consortium looking at 158 patients from 9 centers. And here again, the patients who are in an outpatient were selected, and they had a low LDH and Charleston score. They were expected to have a lower risk of toxicities. And indeed, we treated 55% of patients outpatient, and of those, most did not get admitted. In fact, only 45% of patients were admitted. All patients with the CRS and ICANS did end up in a hospital. The survival on an inpatient, outpatient treatment was comparable, and duration of hospital stay was lowered from 13 down to 5 days. And if you look at the reasons for admission, of course, it's mostly CRS or ICANS or the combination of both, but also some patients were admitted with infections, with a disease progression, and some other reasons. Moving on to axi-cel and brexu-cel, there is a limited experience, but we've seen on this meeting the increasing courage we have to move these products into outpatient setting. This is one of the first reports, series of 13 patients treated with the brexu-cel and axi-cel. And as you see, all of them except 3 ended up being admitted within a median of 3 days after CAR-T infusion. And only 2 patients received a prophylactic oral dexamethasone. But again, the toxicity was manageable, and a PFS and OS is very comparable to what had been reported in a trial. Is the outpatient CAR-T cell feasible for older patients? So in this interesting single-center experience, they compared outpatient CAR-T cell outcomes in patients who are older than 65 to those who are younger. And as you see, the range is 67 through 77 years of age. And almost all, so 86% of the patients ended up being hospitalized. The inpatient stay was about 10 days. Time to admission was 4 days. But if you look at it's similar to younger patients. Certainly, one important difference to note, that while CRS is the same in terms of the incidence, the ICANS is twice as high. Older patients do have higher risk of ICANS. It's not only higher, but it's also more protracted. Duration is 10 days in older patients compared to 5 days in younger patients. So this is important if we think about doing the outpatient for older. They need really a very good support. Liso-cel is one of the products with a delayed onset of CRS and ICANS, and therefore even the clinical trials were allowing the outpatient treatment in an ambulatory setting. And this study summarizes the experience in these 3 prospective studies looking at 53 patients. 43% did not require admission, and for those who did, the median stay was only 6 days compared to 15 days if they received the CAR-T inpatient and were followed all the way through. So this seems to be a very good product to really bring to outpatient setting. If there is no experience, I would choose this product as one of the most feasible for outpatient administration. Again, in terms of the quality of life and patient-reported outcomes, here is the comparison of outpatient and inpatient liso-cel administration. And as you can appreciate, this is a change from baseline. In both settings, there is an improvement in functioning, cognitive functioning, fatigue, pain, but there are no differences in outpatient and inpatient. What is different is a number of days in a hospital, but I think there is more research needs to be done in a quality of life parameters. This is an interesting strategy I wanted to show you. So when we talk about outpatient administration, some groups, such as this single-center study, took an approach of preemptive admission on day +1 or +2 after CAR-T. So this is for the patients, for the products which are high risk of toxicity: brexu-cel, axi-cel, ida-cel. These 3 products for the patients after the admission, they were after infusion, they were electively admitted directly to the hospital for monitoring, and it seems to be a safe approach. On this meeting, we heard an important presentation on experience using cilta-cel in an outpatient setting. 24 patients with a relapsed refractory multiple myeloma. They received outpatient LD chemotherapy, CAR-T infusion, and daily 14 days monitoring in an outpatient unit. And then they were admitted with the fevers. So 83% ended up to be hospitalized. Median duration was 4 days, but median time to hospital was almost a week, 6 days. So we really gave patients a week to be at home, and they were admitted with the first fever. So this demonstrates the safety and feasibility of an outpatient cilta-cel with an appropriate infrastructure and appropriate patient selection. So what are the potential advantages? Of course, it's a patient preference, it's a comfort, it's a convenient, there is a reduced risk of infections, reduced utilization of resources. We have been shortage in a bed, in inpatient personnel, staff, healthcare cost utilization, and it's probably a financially more sustainable model given the lower days in the hospital. So when we talk about a new practice of outpatient CAR therapy, it really means that after the CAR T-cell infusion, which is safely infused outpatient, the daily monitoring of a patient can lead to either preemptive admission for those with a high risk, admission with a first fever, which is either CRS or ICANS, or outpatient management of the low-grade CRS, which some centers such as UPenn or others are really equipped to do with a very well-built infrastructure. So we are really shortening the length of stay. So here is the expert panel opinion from the ASCTC, which is available to you and really lists the selection criteria for patients and for logistic and infrastructure needed for this to be feasible. And there are some logistical challenges, patient-related and center-related, and I think David is going to spend more time on how to develop the infrastructure and solid outpatient facilities, SOPs, and all other materials necessary for outpatient monitoring. So in terms of the future trends, I think that we have to have better tools to find the risk factors and to identify novel biomarkers for ICANS. So you can say, okay, we are going to send this patient back from the clinic, although we have this biomarker which is differentiating the outcome. I think the prevention strategies should be more widely implemented. Wearable devices are used. I am not a big fan, but perhaps for some centers it may make sense. We have been using some AI tools. We developed early detection tools for ICANS, which is being tested in a prospective study. It's a phone call using IA prompter to understand your language and early cognitive imbalances, which can be a prodrome to ICANS. And then the need to develop maybe new model of facilities where the connection between inpatient and outpatient is more fluid. And with that, I want to thank you for your attention. I want to thank patients and their families for their courage and trust that they put to us to help them through their difficult journeys.
Thank you, Dr. Bakanova, for an excellent review of the published literature on outpatient therapy. That was really good. So I also want to go back briefly to the referral patterns that we see with CAR-T. And it's going to be a little prelude before Dr. Potter comes on. So again, the 60-year-old with refractory lymphoma, the 28-year-old with refractory ALL, and the 70-year-old with refractory multiple myeloma. Can we actually provide service to these patients in the outpatient setting? How do we make it work? And how do we ensure adequate safety? And what important quality metrics do we have to include? So with that as some thoughts in your mind, I would like to invite Dr. Potter to come and continue his part of the talk.
Well, thank you. I'd like to thank PeerView and Dr. Olalekin for the invitation to talk to you today. I am going to review a little bit about outpatient CAR T-cells in action and give you a little bit of a suggestion of how we might develop some models for staffing and overcome some of the challenges that we all have at our institutions. Now, you've heard this, and some of this is obvious. But the advantages of doing this in an outpatient setting are certainly patient satisfaction and convenience. Many of our patients would much rather do this at home in the comfort of with their own family and their own caregivers. We think that should improve quality of life. Importantly, this will conserve inpatient resources and hospital utilization, which is critically important in today's environment. It was particularly important during the COVID pandemic, but even as we've come out of the pandemic, hospital beds are packed, they're full, emergency rooms are packed, there is a nationwide inpatient bed and staffing shortage. And the home environment and focused care teams, we really think can improve medical care. Furthermore, this is a model that we think will be financially sustainable. But when we think about CAR T-cell management, as you just heard, it really is all about the toxicity, particularly managing cytokine release syndrome and neurologic toxicity. Now, the toxicity, the toxicity may and likely is dependent on the anatomy of the CAR being used. The different co-stimulatory domains are in large part responsible for different toxicity profiles. When we think about medications like axi-cel and brexu-cel that have a CD28 co-stimulatory domain, they may have a different toxicity profile compared to those with a 4-1BB co-stimulatory domain. And that will have important implications for site of care, whether we can use all these products in an outpatient setting. So when thinking about the location of care, number one, always, certainly at our center, is clinical outcomes, and that includes both response and safety. We will choose the best product that results in the best outcome, the best responses in the safest possible manner. If we assume that there are different products that can be given safely with equal efficacy, then we can decide between an inpatient and outpatient environment. We will use inpatient therapy when CRS and neurologic toxicity are frequent. When they are early in onset, we can predict they will happen quickly, and when they're anticipated to be severe. We'll do outpatient management when CRS and neurologic toxicity is anticipated to be less common or delayed in onset and anticipated to be more mild or more moderate. Of course, to do this, both in an inpatient and outpatient setting, takes an enormous effort. You've all heard the expression, it takes a village. I will tell you it takes much more than that. It takes a city, if not more. We think about this being focused on the patient and all the different services that touch a patient's episode of care, from the insurance approval to the billing, to social services and the data reporting requirements, laboratory assessments, cell manufacturing, and all these other services, and then all the medical care that goes around this and all the people that have to be trained. Inpatient units, outpatient units, our faculty, fellows, residents, emergency rooms, ICUs, all the consultative services, our pharmacy, etc. And to do this safely in an inpatient setting or an outpatient setting, all these people have to be aware of what's happening. You have to identify these staffs and departments ahead of time. When these products were first approved, the REMS requirements, I will say, were somewhat vague, but if you read them really literally, anybody who touched a patient's episode of care had to be REMS trained. When Kymriah was first approved in 2017, at my center, we REMS trained over 700 personnel in the hospital. And that could gender some chuckles, I suppose. We read the requirements a little bit differently today, but there are still many, many people that have to be trained. And this is all centered around patient care. Judging from the pre-session polls, I think most people are aware of the importance and central position of the cell therapy coordinator in all of this care. The cell therapy coordinator becomes the liaison with the patient and the care team. They're the patient's advocate and educator. They're critically important for scheduling, for navigation, for financial approval and coordination and integration with the patient. They're a counselor. This was our original cell therapy coordinator. That really is our coordinator, Lizzie Weber. We think she invented this role for us. She, of course, always wanted to be a nurse. You can see she was a little bit older when we hired her. But this is sort of the short version of the care that's necessary to manage this in an outpatient setting. It does start with the cell therapy coordinator. We rely very heavily on our dedicated nurse practitioner support to help manage these patients. We think this is the only way to get them through safely. Of course, you have physician care and input, but you have to have home care available and, of course, family support in an outpatient setting. I'm not going to read through this, but you can see just some of the responsibilities assigned to these different positions. This next slide is really the same thing. It's just expanded. This was from the ASTCT Committee on Cell Therapy Guidelines. You just saw a little bit of this, and this just expands on sort of the abbreviated version that I just saw you. I call your attention to this article published in 2024, and really the infrastructure you have to have in place to set up this program. You've just seen, and I'm not going to belabor this, that when you look at real-world outcomes using outpatient care, outcomes are very similar to what we would anticipate in other settings and similar to clinical trial outcomes. To do outpatient care, it really does depend on the disease and clinical factors such as tumor burden, other risk factors for toxicity, the patient-specific issues such as their proximity to the treatment center, their housing availability. Different centers may have different housing options for patients, transportation, caregiver support, their socioeconomic status, et cetera. And of course, there are institutional factors that are institutionally dependent, resource availability. Some of us, or some of you, I should say, have 24/7 access, and some of us do not. You have to have appropriate outpatient space to manage this. You have to have very quick emergency department access, multidisciplinary expertise, and of course, the reimbursement issues have to be worked out before you start this. So the way that we look at this in deciding the site of care and whether or not patients are appropriate for outpatient management, you have to select the appropriate patient. They have to be physically stable, and of course I put stable in quotes because that may mean something different to all of us, but they have an adequate performance status, they don't have rapidly progressive disease, they have adequate organ function with some reserve to tolerate things like cytokine release syndrome should it develop, appropriate renal function, liver function, lung, heart function, etc. They have to be reliable. You have to know that they're going to do what you ask them to do and what they need to do to get through this safely. And then there may be other risk factor criteria such as the bulk of disease, LDH, and other factors that you heard about. We ask them to be within 1 hour of the treatment center, and they have to have a caregiver available. Some of these toxicities happen before a patient's even aware of it, and having a caregiver allows us to be more quickly aware. And then select the appropriate product. When toxicity, as I mentioned, is slow in onset and predictable, it's really much easier to manage this in an outpatient setting, particularly when it's gradual in onset. You have to have outpatient expertise available around the clock. It has to be easily accessible to the patient. Perhaps telemedicine helps with that. But the ability for frequent, at least in-person evaluations, and I'll get back to what frequent might mean, and appropriate staff training. I will say we've been doing this since 2010 when we administered our first CAR T-cell product. The only point of this slide is to say we have been doing outpatient CAR T-cells now for going on 14 years. This is an old slide, but we've administered over 1,200 CAR T-cell products, the majority of which have been in an outpatient setting. Since commercial application, you see sort of the different products that we use at our center. Now, Dr. Bacanova just showed you some data using CAR T-cells in an outpatient setting, and this was from my center at University of Pennsylvania in a retrospective study that Sunita Nasta and my group put together. And this was the 72 patients who received outpatient tisa-cel. Most of them had bendamustine as lymphodepletion, and 94% were treated as outpatients. And I looked at this, and the slide looks somewhat complicated, but I will tell you it really isn't. They undergo T-cell apheresis, And if you just follow the arrows across, they get their lymphodepletion. They have their clinical evaluation before the cells to make sure they're still eligible to receive them as an outpatient. There are times when a patient may be rapidly progressing during that period, and we will change their episode of care to inpatient admission. But most of these patients get outpatient infusions. We see them on day 2 and day 4 in our office. We then see them day 8 through 30 on a weekly basis, as long as they're okay. We will see them, of course, for urgent visits should they have any signs of toxicity. We use a nurse practitioner in large part to help us see patients with that frequency. And you just saw this slide as well with the outcomes that over half of these patients were managed solely as an outpatient. The average length of stay for those patients was only 5 days compared to patients who received this all as an inpatient. And the outcomes were as anticipated. The outcomes were similar to patients who received a similar product as an inpatient and similar to clinical trial data. But this isn't the only way. I think this is the perhaps less intense outpatient management. We think it can be done because it's predictable and we have staff to help manage these patients. But this was a publication from the Vanderbilt group led by Dr. Olawale and Katie Gatwood, using CAR T-cell therapy and describing what another framework might be. And if you follow this one through, it's got a little bit more intensive care. The patient comes in, they get apheresis, they get bridging chemotherapy, lymphodepletion, and their infusion, and then they're scheduled for daily clinic visits. They have after-hours telemedicine capability. And then suggest that they will see these patients 2 to 3 times weekly in their clinic through day 30, a little bit more intensive than what I just showed you. And another model is described here. This was a multi-center publication and recommendations of a model how other outpatient management may occur. This was also in TCT Journal. And this is much more intensive follow-up. At 6 a.m., the patient calls an inpatient APP to report their overnight events. There's then a 7 a.m. handoff between APPs from an inpatient to an outpatient APP. Between 8 and 10 o'clock, the patient comes into the clinic. They're evaluated. I believe that they then go home or back to their housing. At 4:30 in the afternoon, they come back for a second evaluation. At 10 o'clock, there's a teleconsult with the patient by the inpatient APP who manages them through the night until the 7 a.m. handoff again. Again, this is a very intensive outpatient management model. I provide these different models not to say one is better or one is necessary. We do not know. We certainly know that in some cases the less intensive model is appropriate and safe. But whatever we do this to maximize patient safety. We make sure that they have detailed ongoing education. They get their wallet card that you all are aware patients have to get. We have predefined SOPs for outpatient care. And we have mechanisms for rapid evaluation for toxicity to provide antibiotics, CRS management with tocilizumab and other medications. So there has to be rapid ED and hospital access. To do this, there are a number of options. So you just saw some of this. We can use prophylactic steroids. There have been trials trying to use prophylactic tocilizumab to delay onset or severity of CRS. We can be using telemedicine to maximize contact with the patient for asymptomatic visits. There can be and should be processes to bypass an emergency room. Perhaps wearable monitoring will help us identify patients in the near future. That requires, of course, training. It has to be integrated with the EMR. There's all sorts of issues with data storage and costs and concern about who's going to monitor the outputs. And then question whether it's necessary. Are we picking up toxicity that we wouldn't otherwise pick up just by patient knowledge or caregiver knowledge? So there are also very important financial implications, and it would be naive to discuss this topic without at least mentioning the financial implications of inpatient versus outpatient therapy. Even when admission is required, the overall length of stay is shorter. Hospital resource utilization is less. And I love this quote from Dr. Gatwood from that manuscript I showed you, where she said, Medicare reimbursement in the outpatient setting often leads to healthcare facility, leaves them at a cost deficit. I think that means it costs more. Contrarily, outpatient care does not attract nearly as much of a deficit. That means it's more financially rewarding. Reimbursement contracts are less favorable if patients are admitted within 72 hours of receiving a drug. So again, those products that have very rapid onset may still have major financial concerns compared to those that have more delayed onset. And I think program structure is particularly critical as cell therapy is now going to expand beyond our traditional models of bone marrow transplant and hematologic malignancy indications. And so we've really thought of two different ways that this might be set up. You see the different stakeholders, the BMT group, lymphoma, myeloma, leukemia caregivers, but now we have solid tumor applications and an exploding field in non-cancer applications for cell therapy, such as an autoimmune disease. And the patients can be identified by their home care team and then referred into the cell therapy service, who will then manage them through this episode of care. It centralizes your expertise in cell therapy. There's fewer staff to educate and train, and ease of coordination of resources. I will say what we've chosen to do at our center is to have a more encompassing type of model where the experts in each of these specific diseases develop expertise in cell therapy, and they become part of the cell therapy service. The experts reside within the disease group, and that expands your expertise in cell therapy. And that's certainly ideal for a center that has broad expertise. It expands it. It really enhances the research capabilities of these therapies. And the downside is that it requires more detailed coordination and more resources to do this, and certainly requires a little bit more staffing as the number of caregivers involved is expanded. But I think in summary, yes, this can be done safely. You have to select the appropriate patients, the appropriate products. Your internal infrastructure is critical to have dedicated staff and space and program management. It does require extensive staff training. You have to have your SOPs developed, a procedure for seamless and rapid transition from an outpatient to an inpatient setting, all while maintaining and following really safe protocols, following FACT guidelines. Is really critical to do this appropriately. But with that, I think outpatient CAR T-cell therapy is safe and feasible and even appropriate. And I do believe probably just about everybody in this audience has all the right pieces, and I think it's a matter of putting them all together.
Okay, so we're going to go to the audience Q&A, and my colleagues and I will try to answer them. Judging by the number of questions we really had an engaged audience. So one question was, does outpatient therapy allow you to treat more older patients? Do you have better access to specialized care? I think based on what Dr. Bacanova presented and what Dr. Potter also mentioned, there really is no age that is exclusionary for outpatient CAR-T program. Most of the clinical trials had no age limit. They were done in the inpatient setting. But even in the real-world data, there are older patients that also did very well, even though they were treated in the outpatient setting. Does anyone have additional comments?
I would agree with that. I think that there is data that age probably doesn't matter. It has to do with reliability and I think underlying health. I will say very anecdotally, we're worried, of course, about older patients being more frail and having more toxicity. But we also know that when older patients come into a hospital, there is a whole lot more inpatient toxicity. They tend to end up more debilitated with more complications, and that might actually be a population one might want to think even stronger about for outpatient management.
Thank you. So, Dr. Potter, what are your thoughts about extending outpatient monitoring even beyond the time that we usually do the 14 days? Because we have other toxicities that are being described like IECHS and some of the movement disorders that we see. Would you extend monitoring for those purposes?
We do our outpatient monitoring through about day 30. Because of some of these more delayed toxicities. CRS really happens much before that, but now with some of these newer products, and as you mentioned, this delayed phenomenon of IECHS, some of these happening later. I think still having a close connection with the patient through about 4 weeks, day 28, day 30, is probably most important. Some of the other products, you probably can get away with shorter monitoring if they haven't had toxicity or is completely resolved, but I don't think we're there yet.
Thank you. Dr. Bakanova, these two questions, you can tackle them together. One says, project to the future. Do you see CAR-T replacing auto transplant even if outpatient therapy is more available? Then what are the reasons why it seemed that there were more ICANS in the older patients based on your presentation?
Yeah, so yes, it's based upon a randomized study for, two products. The CAR-T have replaced auto transplant for high-risk patients who are either refractory or relapse within a year post their frontline therapy. So whether it's outpatient, inpatient, it is available, and it's replaced the transplant for those who are for the patients who have a CAR-T for a third-line therapy. Certainly, if they have a well-controlled disease, and many of them are candidates for outpatient. So, I think it is our present that the CAR-T has replaced the auto transplant. In terms of the second question, why is the ICANS more common in older patients? I think it could be just related to the difficulties for a hospital stay. There is just kind of a tendency for the delirium, and perhaps just whole hospital environment impedes their and so I think that it's not well recognized, and I am not entirely sure why, but I think there are issues related to that. Perhaps the endothelium is just, more prone to injury as the patients are aging and have more comorbidities. Perhaps that could contribute. And I think perhaps polypharmacy, other drugs they are on. I mean, there's just such a nuanced management of these patients, especially as they're older in hospital, to try to minimize the toxicities or minimize, how we can hurt them. And that's why the outpatient management and monitoring may be just so much productive for older patients, as they have a good caregiver. They can be brought back and forth. But it's under investigation. Why is that? I think it's not really clear.
Looks like we have a question from the audience.
Here. So, good afternoon. Great session. Navneet Michel from Sierra Canyon. So in the U.S., we have 7 accredited transplant cell therapy programs through our network, and 5 of them offer FDA-approved immunofactor cell therapy along with clinical trials. And we did close to 250 FDA-approved CAR-Ts through our network last year. And 80% of them were done in the outpatient setting. And we use a remote patient monitoring platform, with a central command center with nurses that monitor data. And we set up algorithms and, alerts to help the local teams, manage those patients in the clinic. And the question for the panel is, because this is something we're trying to grapple with, is have you thought about the quality metrics for managing outpatient CAR-T patients? I mean, what are some of your ideas or thoughts on what should be the quality benchmarks, metrics we need to keep in mind to ensure that these patients get the high-quality care safely that we expect them to in this setting?
That's a very good question. I think the question is the quality metrics that you need to put in place. Very, very important. So I will make a first attempt to answer that, and my panelists can also comment. One would be, okay, you want them to live within an hour to be able to get what? Tocilizumab. So your time from the time you meant to give them and to the time that they receive it is a very good quality metric to track. Then when you do want a bed, do they get the bed? Do they not get the bed? Do they have to sit somewhere? I think the transitioning will be, those are two quick quality metrics that come to my mind that you can easily track and that could be numeric. In other words, time to event. You could also track how many were needed to go to the ICU for toxicity, because the theory is that maybe you didn't get them in enough and then they develop grade 3 CRS. I don't know if my panelists have something to add.
Yeah, I think in addition to that, it could be, I don't think the ER is the best care for CAR-T patients, and I would hope that as we get smarter about developing the infrastructure, we can do more direct admissions, especially since that's what patients get, where they have the best care. We know that the CRS and ICANS are not that rapidly progressing as a sepsis, so there is an hour or two to get them admitted, and that should be better. So maybe, one of them would be the ER admissions. I think, other ones are really clearly the admissions and number of days in the hospital there, and the toxicities, really the rates of toxicities, because we certainly want to have efficacy is only going to happen if there is mitigation of the toxicity, and that should be one of the primary outcomes.
Hello, I hope you enjoyed Democratizing the CAR-T experience, which was based on a symposium held during the 2024 Tandem Congress. Doctors Bakanova, Porter, and I are here to answer your questions that were submitted during and after the event on topics related to outpatient use of CAR-T, but also to review a few of the outpatient cellular therapy abstracts that were presented during the Tandem meeting. Veronica, you covered some of the evidence about outpatient CAR-T in your lecture. What other abstracts provided additional information about the outpatient experience with available constructs?
Thank you, Ola. And here are a few additional abstracts presented at Tandem that I thought were interesting and I would like to share with the audience. So the first abstract is a real-world analysis of a CAR-T with the CD19 and BCMA constructs, which used all products, but particularly axi-cel and cilta-cel in an outpatient setting. So 58 patients were managed using the commercial therapy. And the interesting piece about this abstract that these patients were not monitored remotely. And the strategy is just to use clinic, which was open during the day, and an outpatient 24-hour clinic at nighttime, and management of the CRS in an outpatient setting with the tocilizumab for the CRS grade 1. The patients were seen daily for the first 7 to 10 days, and then twice weekly through day 30. And that, as I said, early intervention involved using tocilizumab in an outpatient setting. So 58 patients are described with a median age of 62, and the age goes up to age of 80. The patients were treated for aggressive B-cell lymphoma and myeloma. Only one patient had acute lymphoblastic leukemia and mantle cell lymphoma, respectively. And they used mostly axi-cel and cilta-cel, as I mentioned before. The patients had a very low mortality, only 1.7%. So this appears to be a safe strategy. The median follow-up was 6 months, and the survival, PFS and OS, was comparable to other studies looking at the CAR T cell. But importantly, we here look at the hospitalizations, and 72% in fact were hospitalized within the first 30 days. And most of the time, the hospitalization happened after day 4. As you see in this table, about 40 to 50% patients were hospitalized in between day 4 and 7, and about a third of the patients hospitalized in the first 3 days. And this was mostly for ICANS, neutropenic fevers, and high-grade CRS. The real-world analysis included administration of the tocilizumab in the outpatient setting, as I said, for those patients who had a grade 1 CRS, received tocilizumab in the clinic. The median length of hospitalization was only 4 days and ranged from 1 to 14 days. And so this study really suggests the feasibility of this approach and good outcomes in terms of the safety and efficacy. The second study has been completed by the investigators from the US claims dataset. And this real-world assessment used look at the resource utilization in patients with relapsed refractory large cell lymphoma, which were treated with a liso-cel, and compared to patients who received axi-cel in both inpatient and outpatient setting. It's an interesting comparison. We look at 100 of patients with a liso-cel and over 400 patients with axi-cel. Similar age and gender in both cohorts, and also similar use of the insurance plan type and region of residence. This slide summarizes the results of this study. 44% of patients with liso-cel were treated outpatient compared to 10% who received axi-cel. And the risk of the inpatient procedures and critical care admissions was significantly lower with liso-cel compared to axi-cel, with the odds ratio here between 0.2 and 0.4. Here on the right hand side figure, we summarize the outcomes in patients who receive critical care admissions anytime after infusion. And the odds ratio favors liso-cel compared to axi-cel, which is suggesting that a total of 9% of liso-cel patients versus 18% of axi-cel patients required critical care stay at any time. These are interesting and important data as we look at the health economics burden after CAR T-cell therapy, particularly for those patients treated in the outpatient setting.
Thank you, Veronica. That was awesome. Let's now address a few questions from the audience that we didn't have time to take earlier. Here are some questions about outpatient administration. What are your thoughts about some of these topics?
Thank you, Ola. I will take this first question, which is asking about universal use of prophylactic strategies for outpatient CAR T administration. This is an evolving area, but generally we do not use prophylaxis or prophylactic steroids in all patients. And it's really stratified by the risk to develop CRS or ICANS. Particularly patients with a high LDH and high tumor burden are at risk, and for those we recommend either systemic steroids, dexamethasone and day 0, 1, 2, or increasingly we have been using intrathecal dexamethasone and day +1 and +7, which is one of the strategies we develop in our center. But both of them are effective in preventing high-grade CRS, but not preventing high-grade ICANS. I would also like to comment on a third question, which is what is the recommended frequency of telehealth visits, or what is the recommended monitoring for adverse events in the immediate post-infusion period after CAR T administration on an outpatient setting. And I think this is an evolving field and evolving experience for the different centers approaching this in a different fashion. There are increasingly more comfort to use regular clinic visits and with not really reaching for excessive telehealth monitoring, just because the patients typically have some, this is not a rapidly progressing serious complication. The CRS can be managed within a couple of hours and within a meaningful period of time, where if the patients present to clinic or present to a emergency room, that usually is sufficient. And the telehealth visits, especially looking at the abstract we just reviewed, are really not necessary for safe CAR T administration. The time to recognize icons is important, and that's why the daily visits in a clinic with an in-person, provider is important. But I don't necessarily think that a twice a day or more frequent telehealth monitoring is necessary. I think we are gaining experience and more knowledge about safe monitoring, which is daily for the first 14 days, and then at least twice a week or maybe 3 times a week for the week 3 and 4. We also showed in our recent abstract that the new onset icons or CRS is exceedingly rare after day 14. I also mentioned that with those late toxicities, particularly after CARVYKTI, we do have to be aware of the neurotoxicity which may appear after day 30, but that just requires more awareness in the team which is doing the longer-term follow-up for the patients.
Thank you, Veronica. David, we received a few questions about late effects and resource allocation. Do you have any insights to share?
Well, thank you, Ola. Appreciate the opportunity to be able to respond to some of these questions. There are a number of interesting issues really to take into account. One of the questions was asking about experience of long-term or late effects with CAR T cells, particularly in the context of outpatient care. I don't think this is necessarily specific to outpatient care when we talk about long-term and late effects. The vast majority of these patients, of course, are already being managed in an outpatient setting. There are issues about how to monitor these patients for late effects and long-term toxicities, both at the treatment center, and perhaps what this question is getting at is how do we manage this when we return the patient to their treating physician who maybe doesn't have as much experience with CAR T cells. Late long-term side effects are unusual. The major long-term toxicity that we worry about are things like hypogammaglobulinemia and infection, and of course, relapse, which I wouldn't exactly call a side effect. We tried to be very good about communication with the referring physician, with the referring care team. We discuss issues related to particularly hypogammaglobulinemia, monitoring for immunoglobulins, and then we discuss which patients may or may not benefit from repletion. And I will say that's a very personalized decision. Things like late cytokine release syndrome after that 28-day intensive monitoring really doesn't happen. There are some reports of late neurologic toxicity or patients who haven't fully recovered. In those situations, we either monitor them closely in our outpatient
practice, or we remain in very close contact, both with the patient but with their primary care team. And so we've devised an infrastructure to really help keep track of these patients. And I just think finally, when we return these patients to their primary care team, usually at around a month, day 28, we also see them back. It's not just kind of a once and done treatment. We depending on how far they live from our center, we typically might see them on month 2 or at least on month 3, and then periodically after their treatment course. And so we do stay in contact both with the referring physician team and with the patient. The second question was about thoughts about outpatient monitoring of delayed toxicities like IEC-HS and how frequently patients should be seen in the ambulatory setting. Of course, we talked about how frequently patients should be seen during their acute episode of care, perhaps during that first 4 weeks. But when we're talking about outpatient monitoring for delayed toxicities, things like IEC, HS, or immune effector cell hemophagocytic lymphohistiocytosis, which has now been well defined by the ASTCT, is something that usually happens during that acute episode of care. While it's not necessarily directly associated with things like cytokine release syndrome, it is often evident at the time of CRS or at the time of resolution of CRS. Developing after this acute period of monitoring is unusual. I think the monitoring programs that are set up for outpatient management in that first 28 days, where patients are seen particularly frequently for the first 14 weeks, and then periodically, perhaps twice a week or even once a week for the last 2 weeks, are usually sufficient to pick up some of these more delayed toxicities like IEC-HS. By monitoring blood counts and monitoring symptoms, this should become evident. When this is suspected, of course, patients should be evaluated in more detail and monitored more frequently. But this absolutely can be monitored, evaluated, diagnosed in an outpatient setting, and patients who are suffering from toxicity that needs inpatient management then can be transitioned to an inpatient setting. The next question was about challenges that we may experience with resource allocation when transitioning from 100% inpatient to an outpatient model. Our biggest challenge with resource allocation is more in the inpatient setting. The resources for an outpatient model have been well defined. We have a good infrastructure. I would imagine most centers with a robust transplant program have the infrastructure to manage outpatients. One of the biggest challenges for us is the transition from the outpatient setting to an inpatient setting. And I guess that's a big challenge with resource allocation. When a patient gets treated as an inpatient, they're already there. When they have toxicity, there are no issues with transition. In this day and age, many health systems have emergency rooms that are packed, inpatient units that are completely full. And these patients who get CAR T cells and experience toxicity like cytokine release syndrome need to be treated as if they are having, and they are indeed having, a medical emergency. So to make an outpatient model work, you have to have rapid access to either an experienced emergency department, or even better, direct admission to an inpatient setting that has experience in managing the CAR T cell toxicities. If there are no beds, if the emergency room is overflowing and these patients can't get rapid care, centers have to figure out resources that allow them rapid transition from an outpatient to an inpatient setting. And to me, that's what's critical about setting up an outpatient model for care. And Ola, I'm going to turn this back to you and see if you have any additional comments about this.
Thank you, David. That was really good. I can address these last few questions. One question was about how we can prevent certain group of patients, those who have limited or not as good home support so that they are not disproportionately disadvantaged from treatment in the outpatient setting? This is a very important question because, as we all know, resources are not available for everyone at every time. And we did talk a lot about the need for a caregiver and some social support. Many people have to travel to be able to do CAR-T therapy. And how do we make sure that they are not disproportionately disadvantaged? Well, there is no way around the need for a caregiver. There is no way around the need of social support. The treatment for CAR-T involves others apart from the patient, people who can watch over them, and they often need to move away from where they are to get the treatment at a different center. And there are often multiple visits around the time of infusion, particularly when it is done in the outpatient setting. However, there is hope on the horizon. We can leverage telemedicine options so that, for example, a patient who is doing well, maybe 1 or 2 weeks after they receive the CAR-T, probably some of the inpatient visits can be transitioned to virtual, completely labs locally, and telemedicine to be done locally. One other option would be to use wearable devices that may also help patients to stay more in their home or maybe in a different place apart from the hospital. Those would be the things that we can use to support the patients who have to travel to get their CAR-T. But for the early part, when they have to be monitored very closely in the tertiary center or where the CAR-T is administered, we really have no option other than for some caregiver support and the frequent visits because they are essential for patient safety. But as they get further out, we can use more telemedicine and more wearable devices so that they don't need to come to the treatment setting as such, and so that even their caregiver can have a break here and there to be able to provide adequate care for the patients so that they don't get fatigued. The second question is about what the recommendations are to overcome barriers such as lack of caregiver support, housing costs, and equitable access to care when trying to develop an outpatient CAR-T program. This is a very important question, and it is important for what we do to really be equitable, particularly in the care delivery that is provided. So, for caregiver support, I think what is very important is to be sure that the education program is not just adding knowledge to the caregiver, but it gives the caregiver a sense of comfort or a sense of confidence that they can provide the care. Housing costs are really a problem nowadays because many of the CAR-T centers, the tertiary institutions, are in big cities, and the cost of living has gone up significantly, which can present a hardship for many patients who have to relocate for a month or two to get their CAR-T treatment. One good thing is that most of the commercial products, the sponsors are able to provide some cost that is able to help with the housing costs. And there are foundations or other philanthropic money available to the tertiary centers that can be accessed to cushion this cost for patients. In our center, I can tell you that we have a dedicated staff that helps navigate all the possible available sources so that patients have access to those. And the feedback we have received from patients is that they have found that very helpful to cushion the cost. In terms of providing equitable access to care, one possible way to do this is to make that a quality metric that is followed longitudinally. In other words, the patients that we serve, do they feel that this care was provided in an equitable fashion? The staff that provide the care, do they feel that it was provided in an equitable fashion? And I think if we do some of those quality metrics, it would actually help. Now, if a caregiver is unavailable, it is really difficult to provide CAR-T for a patient. This is not a problem unique to CAR-T. Even autologous and allogeneic transplants are unable to be given if there is no caregiver available. Now, in such a case, one possible option is to consider alternative therapies that the patient can be on while they source for a caregiver. It may not be one person for the 30 days. It may be a calendar that is populated by one person from this day to this day, another from this day to this day, so that patient is not left uncovered. We have not found hired caregivers to be as helpful because sometimes they call out. In other words, they may not be as vested in the caregiving process, but the caregiver that the patient sources for themselves, be it family, be it friend, those have been a little bit more reliable. So that concludes our supplemental Q&A. I hope we were able to provide some answers and feedback that was useful for your practice. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HKJ860. This activity is supported through educational grants from Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Novartis Pharmaceuticals Corporation.